Welcome, everyone. I'm excited to kick off today's presentation on the comprehensive neurologic assessment in respiratory care. Today, we'll explore how evaluating the nervous system is crucial for managing respiratory patients effectively. We'll cover key assessment techniques, the impact of neurological function on breathing, and how to apply this knowledge in clinical practice. I look forward to sharing this important information with you. Let's get started. Today, we're going to focus on the neurologic assessment of the respiratory patient. This is a crucial part of respiratory care because the nervous system plays a vital role in controlling breathing and airway protection. When we evaluate a patient neurologically, we're looking at how well their nervous system is functioning and how it might be impacting their respiratory status. A comprehensive neurologic assessment involves examining various aspects, including mental status, cranial nerve function, motor and sensory responses, reflexes, and coordination. By thoroughly assessing these areas, we can identify any neurological deficits that could compromise breathing, such as impaired airway reflexes or muscle weakness. It's important to remember that neurological issues can sometimes be subtle, but have significant effects on respiration. For example, a patient with a brain injury or neurological disorder might not be able to protect their airway effectively, leading to increased risk of aspiration or respiratory failure. So, in our overall approach to respiratory care, paying close attention to neurologic health helps us develop better treatment plans and intervene early if problems arise. This way, we can improve patient outcomes and ensure safe, effective management of their respiratory needs. Neurological assessment plays a crucial role in respiratory care because a patient's neurological function can directly affect their ability to breathe. This is why conducting a thorough assessment is so important. First, we look at the sensory system, checking how the patient responds to stimuli and testing various reflexes to ensure the nervous system is functioning properly. These reflexes can tell us a lot about the integrity of the nervous pathways. Next, we assess the motor system, focusing on muscle strength and movement. We also perform coordination tests to identify any issues with motor control, which could impact breathing or overall function. Cranial nerve function is another key area. Evaluating these nerves helps us understand how sensory and motor pathways connected to the brain are working, giving us insight into potential neurological issues. Mental status is a vital component of the assessment as well. It helps us gauge cognitive and emotional functioning, which can influence respiratory management and overall patient care. Finally, this entire process, often called a neuro exam, is aimed at evaluating the nervous system to better understand the patient's condition and guide our treatment approach. All of these elements together give us a comprehensive picture of the patient's neurological health, which is essential in providing effective respiratory care. Let's take a closer look at the functional neuroanatomy involved in respiratory care. First, we have the cranial nerves. There are 12 of them, and they play crucial roles in controlling many functions, including those related to breathing. Then, there are 31 spinal nerves, which also contribute significantly to our nervous system's function. These nerves are part of what we call the peripheral nervous system, or PNS. The spinal cord is a vital component of the central nervous system, or CNS, connecting the brain to the rest of the body. Speaking of the CNS, it encompasses the brain structures like the cerebrum, the brain stem, and the cerebellum, all of which coordinate complex functions, including respiratory regulation. In brief, the neurologic system is composed of two main parts: the central nervous system, which includes the brain and spinal cord, and the peripheral nervous system, made up of all the nerves extending throughout the body. Understanding this division helps us appreciate how signals are generated, processed, and executed, especially when it comes to managing respiratory functions effectively. The cerebrum plays a critical role in many of the essential functions of our brain, making it a key focus when we consider neurological health. Its significance cannot be overstated, especially because damage to the cerebrum can impact our emotions and memory, two vital aspects of our daily lives. When there's injury or lesions in this area, It can lead to abnormalities in movement, affect levels of consciousness, and even impair our ability to speak or write. This shows just how interconnected and complex the cerebrum truly is. Now, the cerebrum is divided into 4 main lobes: the frontal, parietal, temporal, and occipital lobes. Each of these has specialized functions that contribute to our overall cognitive and motor abilities. And of course, it's the largest part of the brain controlling specific intellectual and motor functions that are fundamental to our interaction with the world. Understanding these aspects of the cerebrum helps us better assess and manage neurological issues in respiratory care and beyond. Let's explore how injury to the cerebrum can impact various functions. When the cerebrum is affected, it can lead to changes in emotions, making a person feel different or exhibit altered emotional responses. Memory can also be compromised, which highlights how vital this brain region is for our daily functioning. Moving on, damage to the cerebrum can impair communication skills, such as the ability to speak and write effectively. This is because the areas responsible for language are located within this part of the brain. Additionally, lesions or injuries to the cerebrum can cause abnormalities in movement, which might manifest as weakness, tremors, or coordination issues. It's also important to note that such injuries can influence the level of consciousness, or LOC, ranging from drowsiness to coma depending on severity. Now, looking at the structure of the cerebrum, it's made up of 4 lobes: the frontal, parietal, temporal, and occipital lobes. Each of these lobes has specialized functions, contributing to our overall cognitive and motor abilities. The cerebrum is the largest part of the brain, and it plays a crucial role in controlling specific intellectual tasks and motor functions. Understanding its anatomy and functions helps us grasp how injuries can lead to various neurological deficits, which is essential in providing comprehensive neurologic assessments, especially in respiratory care. Let's take a closer look at the functional neuroanatomy involved in respiratory care, starting with the brainstem. The brainstem plays a crucial role because it acts as a vital connection between the brain and the spinal cord, essentially serving as a communication highway. It's responsible for regulating some of our most vital functions, like heart rate, blood pressure, and breathing. These are automatic processes that we don't consciously control, but they're essential for survival. Most importantly, the regulation of these vital functions takes place in the brainstem, highlighting how central it is to maintaining life-supporting processes. Another key point is that most cranial nerves originate in the brainstem. These nerves are essential for sensory and motor functions of the head and neck, and many of them also play roles in respiratory function and reflexes. Now, the structure of the brain stem itself is composed of the lower parts of the brain, which include the midbrain, pons, and medulla oblongata. This structural organization allows it to perform its crucial roles efficiently. Understanding this, especially in the context of respiratory care, underscores the importance of the brain stem in monitoring and regulating respiratory patterns, which can be affected in various neurological conditions. Let's take a closer look at the cerebellum and its role in our neurologic function. Issues in the cerebellum can lead to noticeable disturbances in gait and balance, which are critical for mobility and safety. When the cerebellum isn't functioning properly, you might see tremors or involuntary shaking, highlighting how essential this area is for smooth movement. Abnormalities here can also cause ataxia, which is a loss of muscle coordination, making movements clumsy or unsteady. This underscores just how vital the cerebellum is for precise motor control. The cerebellum is responsible for maintaining equilibrium, muscle tone, and coordinating muscle movements, all of which are crucial for normal respiratory function and overall physical stability. You'll find the cerebellum located at the posterior part of the brain, tucked away at the back, but its influence extends throughout our motor system. Understanding the cerebellum's functions helps us appreciate how neurological issues can impact respiratory care, especially when coordination and balance are compromised. Let's take a closer look at the functional neuroanatomy involved in respiratory care. Damage to certain areas can lead to complete diaphragmatic paralysis, which significantly impacts breathing. Now, the phrenic nerves on both sides are crucial here. They innervate the diaphragm, allowing it to contract and enable respiration. These nerves originate from the cervical spinal cord, specifically from the C3 to C5 levels, which are often called the phrenic nerve roots. The pathway of these nerves extends from the base of the brain down to the first lumbar vertebra, or L1, and they are approximately 45 centimeters long. This anatomical extent highlights how vital the connection is between the brain and the diaphragm for motor control and sensory input. Overall, the spinal cord acts as a major highway, connecting the brain to the body. It transmits motor commands and sensory information, which are essential for coordinated breathing and other vital functions. Understanding this neuroanatomy helps us appreciate how injuries at different points can disrupt respiration, emphasizing the importance of comprehensive neurologic assessment in respiratory care. Let's take a closer look at the assessment of consciousness, which is a crucial part of comprehensive neurologic assessment in respiratory care. As outlined in Box 6.1, there are different levels of consciousness that we need to understand. When we talk about a fully oriented patient, we expect them to respond in detail to questions about their name, the date, and their current location. This helps us gauge their awareness and orientation. The assessment of consciousness begins the moment we first encounter the patient. We look at both wakefulness and alertness, that's the level of consciousness, and also at the content of consciousness, which includes awareness and thinking processes. For example, if a patient is delirious, their levels of consciousness may fluctuate, and they often have significant issues with attention and organized thinking, leading to confusion. To evaluate delirium, tools like the confusion assessment method for the ICU or CAM-ICU are frequently used. This helps us systematically identify delirium in critically ill patients. Finally, when we discuss coma, we're referring to a state where there is a complete absence of arousal and awareness. In other words, the patient is unresponsive, and we cannot assess their thinking or awareness because those functions are absent. Understanding these distinctions is vital for accurate assessment and appropriate management in respiratory care settings. Now, let's take a closer look at levels of consciousness. Understanding a patient's level of consciousness is fundamental in a comprehensive neurologic assessment, especially in respiratory care. It helps us gauge brain function and determine the severity of neurological impairment. On this slide, you can see that consciousness is often categorized into different levels, ranging from full alertness to complete unresponsiveness. Recognizing these levels allows us to observe changes over time, which can be critical in managing patient care effectively. For example, a patient who is alert and oriented is at the highest level of consciousness, indicating that their brain is functioning well. Conversely, if a patient is minimally responsive or unresponsive, we need to act quickly to identify and address underlying issues. Understanding these levels also guides our interventions, whether it's adjusting ventilator settings, providing medications, or planning further neurologic evaluation. Remember, maintaining a thorough assessment of consciousness levels is key for early detection of deterioration and for tailoring our respiratory care to the patient's current neurologic status. Let's discuss the assessment of consciousness, which is a crucial part of comprehensive neurologic assessment in respiratory care. A patient with delirium typically shows alternating levels of consciousness and significant deficits in attention and organized thinking, which we often refer to as confusion. Delirium is commonly evaluated using the confusion assessment method for the ICU or CAM-ICU to help us identify it efficiently. It's important to recognize that two common conditions seen in hospitalized patients are coma and delirium. Studies indicate that delirium occurs in about 60 to 80% of patients who are mechanically ventilated, highlighting how prevalent this issue is in critical care settings. In delirium, patients may appear to have no arousal or awareness, which makes assessment challenging but vital. Some patients who initially suffer severe neurologic injuries may end up in a persistent vegetative state. In such cases, the eyes might be open, but the patient is not truly aware of their surroundings. They do not respond to verbal stimuli or commands in a meaningful way, do not track moving objects or individuals, and do not react to environmental changes. Unfortunately, the prognosis for patients in a persistent vegetative state is usually poor. So, to summarize, delirium involves fluctuations in consciousness and attention deficits, while coma is characterized by a lack of arousal and awareness. Understanding these states helps us better evaluate and manage our patients' neurologic health within the overall scope of respiratory care. Now, let's take a closer look at the Glasgow Coma Scale, or GCS, and its role in comprehensive neurologic assessment in respiratory care. First, it's important to understand that while the GCS is a valuable tool, it does have some limitations. For example, the scale is less effective in patients who have impaired verbal responses, such as those with aphasia or who are tracheally intubated. In these cases, assessing verbal responses becomes challenging, so we need to interpret the scale with caution. Next, let's talk about what the scores mean in terms of patient severity. A GCS score below 9 indicates a severe coma, which often requires airway management, such as endotracheal intubation, to secure the airway and assist with ventilation. This threshold helps us identify patients who need immediate and more aggressive intervention. Moving on, a score between 9 and 12 signifies a significant neurologic insult. This range suggests that the patient has experienced a notable brain injury, but might not yet be in a deep coma. It's a critical range that calls for close monitoring and assessment. For patients with a GCS score between 12 and 15, typically, they are stable enough to be observed outside the intensive care unit. These patients are less critically impaired, but still require careful neurological monitoring to ensure their condition does not worsen. Finally, it's important to remember that the GCS scale ranges from 3 to 15. A score of 3 represents a deep coma or even brain death, while a score of 15 indicates full consciousness. This range provides a broad spectrum for us to gauge the level of consciousness and neurologic function, guiding our clinical decisions effectively. Let's take a closer look at the Glasgow Coma Scale, or GCS, which is a crucial part of the comprehensive neurologic assessment in respiratory care. This scale helps us determine the level of consciousness in our patients. When a patient scores lower than 8 or 9, it indicates a severe coma. In such cases, these patients often require immediate intervention, typically endotracheal intubation, to secure their airway and ensure adequate ventilation. Moving to scores between 9 and 12, we see a moderate level of coma. This suggests a significant neurological insult, but the patient's condition is not as critical as in severe coma. These patients need careful monitoring and management, but they may not always require intubation right away. Finally, scores of 12 to 15 usually indicate mild conditions. Patients in this range are often alert enough that they do not need ICU admission and can be managed with less intensive support, depending on their overall clinical picture. Understanding these distinctions helps us tailor our interventions effectively and prioritize patients who need urgent care. So, the GCS provides a valuable, quick snapshot of neurological status, guiding us in making timely, appropriate decisions in respiratory management. Let's take a closer look at the Mini-Mental State Examination, or MMSE, which is a key tool in comprehensive neurologic assessment, especially in respiratory care. This test helps us evaluate cognitive function across different levels of impairment. First, when we talk about severe dementia, a score below 10 suggests significant cognitive decline. That's an important threshold because it indicates a profound impairment that requires careful management. Next, scores between 10 and 19 are indicative of moderate dementia. This range tells us that the patient has noticeable cognitive challenges, but they may still retain some function and potential for intervention. On the other end, a score of 27 or above reflects normal cognitive function. This suggests that the individual is functioning within typical cognitive parameters, which is reassuring in many clinical scenarios. Finally, it's helpful to remember that the MMSE is scored out of a total of 30 points. It's a straightforward, quick questionnaire that provides valuable insight into a patient's cognitive health. Connecting this to our overall theme, understanding these thresholds helps us tailor respiratory care plans appropriately, especially when cognitive impairment might influence treatment compliance or communication strategies. Now, let's take a closer look at the Richmond Agitation Sedation Scale, which is a useful tool for assessing neurological status in respiratory care. Starting with the lowest end of the scale, an unarousable patient is assigned a score of -5. This indicates a patient who is completely unresponsive, not waking up even with vigorous stimuli. Moving up, we see the range includes a combative and violent patient, which can be as high as +4. This represents someone who is hyperactive, agitated, and potentially difficult to manage, especially in critical care settings. At the middle of the scale, a 0 indicates an alert and calm patient. This is the ideal state where the patient is responsive, cooperative, and stable. Understanding these points helps us gauge a patient's neurological and agitation status accurately, which is essential for tailoring appropriate interventions and ensuring safety. Remember, this scale connects directly to how we monitor and manage patients in respiratory care, helping us make informed decisions at every stage. When assessing light touch, pinprick, and temperature, it's essential to compare one side of the body with the other. This comparison helps us localize the specific site of any abnormality more accurately. By looking at the differences between sides, we can determine if a lesion is affecting the sensory pathways on one side or perhaps both. The main sensory modalities we focus on are pain and temperature. These are particularly important because they're often affected in many neurological conditions, and changes here can point us towards specific issues. During the sensory examination, we have the patient respond to stimuli applied at specific locations on the body. This systematic approach allows us to evaluate the integrity of the sensory pathways precisely. The purpose of this sensory examination is to gather detailed information about the patient's sensory function. It helps us identify abnormalities, localize lesions, and understand the extent of neurological impairment. By thoroughly comparing sides and carefully testing these modalities, we can make more accurate assessments, which ultimately guides our diagnosis and treatment planning in respiratory care and beyond. Let's take a closer look at the motor strength assessment. When evaluating each extremity, we grade the muscle strength on a scale from 0 to +5. 0 indicates no movement at all, while +5 represents full range of motion with maximal strength. This helps us quantify the patient's motor function accurately. In cases where the patient is unconscious, we shift our focus to assessing their response to pain stimuli. This involves applying sternal pressure, nail bed pressure, or squeezing the trapezius muscle. These methods give us an idea of their neurological responsiveness when they can't follow commands. Speaking of commands, when the patient is awake and cooperative, we assess their ability to move on command. It's essential that they understand what we're asking and are willing to cooperate. This ensures the assessment is valid and provides meaningful information about their motor function. Overall, this motor examination is a key part of the comprehensive neurologic assessment in respiratory care, helping us determine the patient's neurological status and guide our management effectively. Now, let's look at the motor examination, which is a crucial part of the comprehensive neurologic assessment in respiratory care. Here, we observe the patient's arms and legs being held out straight, with the forearms pronated, toes pointed downward, and the head and neck arched backward. This position helps us assess the body's response to certain stimuli. We often see two characteristic postures that can indicate different levels of brain injury. The first is decerebrate posture, where the patient appears stiff, with bent arms, clenched fists, and legs held out straight. This posture suggests a lesion at the level of the brainstem, indicating severe brain injury. The second is decorticate posture, which involves abnormal flexion of the arms and wrists, often with the legs extended. Recognizing these postures is vital because they give us clues about the severity and location of brain damage, informing our clinical decisions. Understanding these motor responses is key to evaluating neurological function, especially in critically ill patients, and helps us tailor appropriate interventions. Let's take a closer look at deep tendon reflexes, which are a crucial part of a comprehensive neurologic assessment in respiratory care. On this slide, you'll see the reflex grading scale, which ranges from 0, meaning no reflex response, to +2, which is considered normal, and up to +5, indicating hyperreflexia. This scale helps us quantify the reflex responses and monitor neurological function effectively. It's important to test these reflexes in any patient with a spinal cord injury because they provide vital information about the integrity of the spinal nerves. For example, the patellar reflex, or knee jerk, is a classic deep tendon reflex that we use to assess nerve function. To define deep tendon reflexes, they are involuntary responses that occur when a specific tendon is tapped, stimulating the associated nerve and muscle pathway. By evaluating these reflexes, we can gain insights into the health of the nervous system and detect any abnormalities early on. Overall, understanding and assessing deep tendon reflexes is fundamental in managing patients with neurological or spinal cord issues, especially within the scope of respiratory care. Let's take a closer look at deep tendon reflexes, which are an essential part of the comprehensive neurologic assessment in respiratory care. On this slide, you'll see the reflex grading scale, which ranges from 0 to +5. A grade of 0 indicates no reflex response at all, while +2 is considered normal. If you observe a reflex at +5, that suggests hyperreflexia, which can indicate an overactive reflex pathway. It's very important to test these reflexes in any patient with a spinal cord injury because they provide valuable information about the integrity of the spinal nerves. Specifically, when we talk about deep tendon reflexes like the patellar reflex or knee jerk, we're evaluating the function of the spinal nerves involved in that reflex arc. The main purpose here is to assess the functioning of the reflex pathways, which can help us identify any abnormalities or changes in nerve function. This kind of testing is crucial in our overall neurologic assessment because it gives us insight into the level and severity of nerve involvement, especially in patients with spinal injuries. So, in summary, understanding and grading deep tendon reflexes helps us monitor neurological health, guide treatment decisions, and ultimately improve patient outcomes in respiratory care settings. Let's talk about superficial reflexes, specifically focusing on the Babinski sign, which is an important part of a comprehensive neurologic assessment in respiratory care. First, it's interesting to note that a positive Babinski sign can actually be normal in very young children, typically those between 12 to 18 months of age. During this period, the nervous system is still developing, so this reflex doesn't necessarily indicate any problem. However, in older children and adults, a positive Babinski sign is generally considered abnormal. It's a key indicator that there may be some neurological issues needing further investigation. Now, when we talk about what a positive Babinski sign actually looks like, it involves dorsiflexion of the big toe, meaning the toe lifts upward, and fanning of the other toes. This response is normal in children in that specific age range, but in older individuals, it suggests a possible neurological deficit. It's important to understand that normally, stimulation of the sole causes flexion of the toes, what we call plantar flexion. So, a positive Babinski sign, which involves toe dorsiflexion, is a significant change from the normal response. In terms of assessment, the plantar reflex is the main superficial reflex we evaluate. It's especially important to test this in patients who are unconscious or in a coma, as it can provide valuable information about their neurological status. To sum up, recognizing the age-specific normal responses especially the presence or absence of the Babinski sign, helps us gauge neurological function effectively. It's a vital piece of the overall neurologic assessment in respiratory care. Let's talk about brainstem reflexes and their importance in respiratory care. When both cranial nerve IX, which controls swallowing, and cranial nerve X, responsible for the cough reflex, are absent, it can put the patient at significant risk for aspiration of secretions. This is a critical point because without these reflexes, the body's natural defenses against inhaling saliva or other secretions are compromised. Cranial nerve IX specifically manages the muscles involved in swallowing, and this function is typically tested by evaluating the patient's gag reflex. If the gag reflex is absent, it indicates that this nerve might not be functioning properly. On the other hand, cranial nerve X controls the cough reflex, which we often observe when we suction a patient. If the patient doesn't cough to clear secretions, that could also be a sign of nerve impairment. Assessing these reflexes is especially important in lethargic or comatose patients, as it helps us determine whether the brainstem is still intact. The brainstem is vital because it governs many automatic functions, including these reflexes. So, evaluating the brainstem reflexes provides us with essential information about the patient's neurological status and their ability to protect their airway. Ultimately, understanding and checking these reflexes are fundamental parts of a comprehensive neurological assessment in respiratory care. They help us make informed decisions to protect the patient and manage their airway effectively. Let's talk about the pupillary reflex, which involves cranial nerves II and III. This reflex helps us assess the functioning of the brainstem by observing how the pupils respond to light. When we shine a light into one eye, both pupils should constrict equally, which is a good sign of normal neurological function. We often use the acronym PERRLA to remember this assessment. Pupils are equal, round, reactive to light, and accommodation. This means the pupils should be symmetric in size, perfectly round, and should constrict when exposed to light. Additionally, they should accommodate or adjust when focusing on near objects. Understanding this reflex is crucial because any abnormality, like unequal pupils or a lack of constriction, can indicate potential issues with the brainstem or increased intracranial pressure. Throughout our overall neurologic assessment, checking pupillary reflexes provides vital information about the patient's neurological status, especially in respiratory care, where brainstem function can directly impact breathing. So, always remember to include this simple yet powerful test in your assessment routine. Let's talk about mid-position and fixed pupils. When you see pupils that are fixed in the mid-position, it often indicates severe cerebral damage. This is a very critical sign because it points to brainstem dysfunction, meaning the brainstem might not be functioning properly. Now, moving on to mydriasis, which is when the pupils are dilated or enlarged. This can happen due to serious brain injury, but it can also be caused by certain medications like anticholinergics. It's important to recognize this because it can tell us a lot about what's happening in the brain. On the other hand, miosis refers to pinpoint pupils, very small pupils. This can be a sign of a pontine hemorrhage, which is bleeding in a specific part of the brainstem, or it could also result from narcotics use. Another important concept is anisocoria, which is simply when one pupil is larger than the other. This visible change in pupil size can be a sign of various neurological issues, so it's something we need to observe carefully. Finally, the pupillary reflex involves the cranial nerves II and III. It's a crucial test because it helps us assess brainstem function. If the reflex is abnormal, it can indicate serious neurological problems. So, in summary, observing these pupillary changes and reflexes gives us vital clues about brain health and helps guide our clinical decisions. Now, let's take a closer look at the corneal reflex, which is a key part of our comprehensive neurologic assessment in respiratory care. To test this reflex, you'll want to use a cotton swab and gently touch the cornea. But before you do that, it's important to ensure the subject is fully prepared for the test, so they're comfortable and aware of what's happening. The testing procedure involves lightly touching the cornea with the cotton swab. The expected reaction here is for both eyes to blink. This blinking response is a very good sign, as it indicates that the reflex arc is functioning properly. A normal response to this test means that the reflex is intact, which is essential for protective reflexes like blinking. It's also important to remember that the corneal reflex involves cranial nerves CNV and CNVII. The trigeminal nerve, CNV, handles the sensory input, while the facial nerve, CNVII, manages the motor response that causes the blinking. So, in summary, testing the corneal reflex helps us assess the integrity of these cranial nerves and the reflex pathways. It's a simple yet vital part of our neurologic assessment to ensure the patient's protective reflexes are intact and functioning properly. Let's discuss brainstem reflexes and their importance in respiratory care. Abnormalities in extraocular movement, which involve cranial nerves II, IV, and VI, are actually quite significant in the ICU setting. These movements can tell us a lot about a patient's neurological status and prognosis. One of the key reflexes we rely on is the oculocephalic reflex, also known as the doll's eyes reflex. This reflex is a critical indicator of brainstem integrity. To test it, we turn the patient's head briskly from side to side. If the brainstem is functioning properly, the eyes should move in the opposite direction of the head movement. So when you turn the head to the right, the eyes should shift to the left, and vice versa. If this reflex is absent, meaning the eyes don't move when the head is turned, it suggests a potential impairment of brainstem function. This absence can have important prognostic implications, especially in critical care settings where neurological assessment guides our management. Understanding and assessing the oculocephalic reflex helps us evaluate the level of brainstem activity and can influence our treatment decisions. So always remember, the presence or absence of this reflex provides valuable insight into the patient's neurological health. Now, let's talk about the oculovestibular reflex, also known as the ice or cold caloric reflex. This is a key test we use during a comprehensive neurologic assessment, especially in patients who are comatose. The process involves instilling about 20 milliliters of ice water into the patient's ear. If the brainstem is intact, you'll typically see the eyes move laterally or sideways toward the affected ear. This reflexive eye movement indicates that the pathways in the brainstem responsible for this response are functioning properly. However, if the patient has a severe brainstem injury, the gaze will usually stay at midline. In other words, you won't see that lateral eye movement. This test is crucial because it helps us determine the integrity of the brainstem. Remember, the brainstem controls many vital reflexes and functions, so assessing its status is key in neurologic care. Connecting this to the overall assessment, it provides valuable insight into the patient's neurological function and helps guide subsequent management decisions. Let's talk about the oculovestibular reflex, also known as the ice or cold caloric reflex. This test is used to assess brainstem function, especially in patients with severe brainstem injury. When performing this reflex, if the brainstem is severely injured, the patient's gaze will tend to stay fixed at midline, showing no movement toward the stimulus. This indicates a severe injury. On the other hand, if the brainstem is intact, you'll see a normal response. The eyes will move laterally toward the ear that receives the cold water. This movement is a sign that the brainstem pathways are functioning properly. To perform this test, a physician will instill at least 20 milliliters of ice water into the patient's ear while they are in a coma. It's important to prepare carefully for this procedure to ensure accurate results and patient safety. This reflex helps us understand the level of brainstem integrity, which is crucial in our overall neurologic assessment in respiratory care. Recognizing these responses guides us in determining the severity of brain injury and planning appropriate management. Let's take a closer look at control of breathing. It's a fundamental aspect of respiratory management, and understanding how it works is crucial in our comprehensive neurologic assessment. Essentially, control of breathing involves the intricate coordination between the brain and the respiratory muscles, ensuring that we maintain adequate ventilation at all times. This process is primarily regulated by the respiratory centers in the brainstem, specifically the medulla oblongata and the pons. These centers receive input from chemoreceptors that monitor levels of carbon dioxide, oxygen, and pH in the blood, and then adjust breathing accordingly. It's important to recognize that any disruption in this control mechanism, whether from neurologic injury, disease, or other factors, can significantly impact a patient's respiratory function. For example, damage to the brainstem can impair the initiation and regulation of breathing, leading to hypoventilation or even apnea. Understanding these control mechanisms also helps us interpret clinical signs and symptoms more accurately, guiding our assessment and intervention strategies. So, in our overall goal of thorough neurologic evaluation, assessing the control of breathing provides key insights into the integrity of the central nervous system's role in respiratory regulation. Now, let's take a look at ancillary testing of the neurologic system, which is an essential part of comprehensive neurologic assessment in respiratory care. On this slide, we see two key imaging modalities: magnetic resonance imaging, or MRI, and computed tomography, or CT. Both of these tools are invaluable for visualizing the structural integrity of the neurologic system. MRI provides higher quality images, which means it can give us a more detailed view of soft tissues, such as the brain and spinal cord. This detail is crucial when we're trying to identify subtle abnormalities or lesions that might impact respiratory function. On the other hand, CT scans are used to assess the structural integrity of the neurologic system as well, but they are typically quicker and easier to perform. This speed can be very advantageous in emergency situations where rapid assessment is needed. When comparing MRI and CT, remember that each has its strengths, and the choice often depends on the clinical context. While MRI offers superior image quality, CT scans are faster and more accessible in many settings. Connecting this to the overall theme, effective neurologic assessment through these imaging techniques helps us better understand the patient's neurological status, which is critical in managing respiratory issues that stem from neurologic causes. Now, let's take a closer look at some ancillary testing of the neurologic system. First up is the evaluation of cerebrospinal fluid, or CSF. This test is used to assess for suspected infections, such as meningitis, or other conditions like Guillain-Barré syndrome, which often shows elevated protein levels in the CSF. It can also help detect inflammatory or malignant conditions affecting the nervous system. The typical way we collect CSF is through a lumbar puncture, which involves inserting a needle into the lower back to access the spinal canal. Next, we have electroencephalography, or EEG. This test records the brain's electrical activity, which is crucial when we're evaluating patients with seizures, altered levels of consciousness, or when confirming brain death. EEG provides us with a real-time window into how the brain is functioning and helps guide our diagnosis and management decisions. Both of these tests are essential tools in our respiratory care and neurological assessment arsenal, giving us deeper insights into the underlying causes of neurologic symptoms and guiding effective treatment. Let's talk about intracranial pressure monitoring and its role in comprehensive neurologic assessment during respiratory care. First, cerebral perfusion pressure, or CPP, is the most critical element to monitor. It's essential because when ICP gets close to the mean arterial pressure, or MAP, cerebral perfusion essentially stops. This is a dangerous situation because it can lead to severe ischemic brain injury and, in extreme cases, brain death. So, monitoring CPP is vital, especially in patients at risk for life-threatening intracranial hypertension. It helps us evaluate how effective our therapeutic interventions are and ensures that we maintain adequate cerebral perfusion pressure to protect the brain. The main purpose of ICP monitoring is to assess cerebral perfusion. It also helps us evaluate the risk of dangerous intracranial hypertension and gauge the effectiveness of treatments aimed at reducing ICP. Remember, when ICP gets too close to MAP, perfusion stops, leading to serious brain injury or death. That's why it's crucial to keep ICP levels from reaching those critical thresholds. Elevations in ICP to about 15 to 20 mHg can start compressing the capillary beds, which impairs microcirculation. If ICP rises to 30 or 35 mHg, edema can develop even in normal tissue, further exacerbating brain injury. When ICP approaches 40 to 50 mHg of MAP, cerebral perfusion can't be maintained at all, putting the patient at immediate risk. Normally, the mean ICP in a supine patient is between 10 and 15 mHg. Small fluctuations during the cardiac cycle are normal, but if variability exceeds 10 mHg, it signals serious neurologic compromise that requires prompt attention. Understanding these levels and thresholds helps us better manage patients with potential intracranial hypertension, safeguarding brain function while providing respiratory support. Let's talk about the declaration of brain death. Brain death is an irreversible condition that occurs when all perceptible brain activity has completely ceased. Usually, this results from a severe brain injury, such as a prolonged cardiac arrest or a massive stroke. To determine brain death, a clinical examination is performed by a physician. This involves checking for various reflexes and signs of brain function, which helps us assess whether brain activity is still present. In addition to the clinical exam, confirmatory tests like EEG or imaging studies are often conducted. These tests are crucial because they help verify the absence of brain activity with more precision and certainty. Another important aspect is examining the presence or absence of reflexes such as pupillary, corneal, gag, and oculovestibular reflexes. The absence of these reflexes indicates that brain function has ceased. Finally, the apnea test plays a key role. If the patient shows no respirations during this test, it confirms a lack of brain activity. In most cases, this leads to a formal declaration of brain death and the decision to remove mechanical ventilation. Understanding this process is essential, as it guides us in making clear, ethical decisions regarding end-of-life care. Now, let's discuss the key points regarding the declaration of brain death and the comprehensive neurologic assessment in respiratory care. First, if the CO2 levels increase to 60 mmHg or rise by 20 mmHg above the baseline without any spontaneous breathing, this is highly suggestive of brain death. Next, after monitoring, we redraw the arterial blood gases to assess the CO2 levels accurately. During this process, we observe the patient for about 8 to 10 minutes to check for any spontaneous breathing efforts or clinical deterioration. At the same time, the patient is taken off mechanical ventilation, but we continue to provide 100% oxygen to maintain oxygenation. Before performing the apnea test, we ensure the patient's arterial blood gases are normalized, which is the first step in confirming brain death. This normalization involves adjusting or confirming the gas levels to establish a baseline. Finally, the apnea test involves closely monitoring the patient after removing ventilation to see if there's any breathing effort, with the goal of confirming the absence of spontaneous respirations. Throughout this process, each step is crucial in accurately determining brain death and ensuring a thorough, safe assessment.